Welcome to OncoPharm. I'm your host, John Bazar. I'm the professor of pharmacy practice at the Bill Gatton College of Pharmacy, and this pod is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today we have, first I'm going to talk about a Me Too publication, an also-ran publication on adjuvant immune checkpoint inhibitor in non-small cell lung cancer, and then some updates from genitourinary world from Asco Gu 26. So let's start with Br.31. This is adjuvant durvalumab in non-small cell lung cancer after resection and adjuvant chemo. About 85% got adjuvant chemo. This is the third of these studies to be done. So we have Keynote 091, which is adjuvant pembrolizumab. We have Empower 010, or 010, which is adjuvant atezolizumab in the very similar space. Adjuvant atezolizumab showed an improvement in overall survival. It's FDA approved and our guidelines recommend it for PD-L1 1% and above in the adjuvant setting, like adjuvant treatment for a year for atezolizumab. For Pembro, its approval is for all patients regardless of PD-L1 status. Similar inclusion criteria with regards to stage 1B, which is more than 4 centimeter tumor, all the way up to stage 3A, with resection, often lobectomy, and then adjuvant chemo if they could tolerate it. Now that approval for Pembro is for all patients, but if you look at the stats, we don't know if there's benefit in those who are PD-L1 negative. The PD-L1 positive population is where you saw the benefit, and that brought up the whole cohort. So this was published in JCO in this week's issue. I think it was originally published back in January, actually. And since it was kind of it was not a positive study, I didn't talk about it, but it came back when it was published in print in my e-talk and caused me to look at it a little bit deeper, and I'm glad that I did, because there's some interesting stuff here. Right? If there's obvious benefit to an adjuvant immune checkpoint inhibitor, we should see it consistently, right? We should see consistent benefit regardless of the study, especially if the study have very similar inclusion criteria. So you could say, well, durvalumab's PD-L1, not PD-1 inhibitor like Pembro. Well, atezolizumab is PD-L1 too, so I don't think that would explain it. There is I should say that Br.31 was an academically designed study. It was not an industry-sponsored and designed study. I'm sure they got the drug from free, whoever makes durvalumab, but durvalumab folks didn't write the study. It was some Canadians that wrote the study. Great national anthem they have in Canada. So this was the largest of these three studies. It was 1,200 patients versus 1,000, 1,100 atezo and Pembro, respectively. The inclusion criteria were basically the same as far as the disease criteria, except some notable differences. Durvalumab, this Br.31, explicitly excluded patients who were EGFR or ALK positive. They had to test for it. They had to be demonstrated EGFR and ALK negative before they were included. Now, this is in the adjuvant setting. At the time of the atezo and Pembro studies, that wasn't done because we didn't necessarily have a reason to do adjuvant TKI like we have some data now. What that means is if, especially for these atezo and Pembro studies that are industry-sponsored, large international studies, they're going to be done all over the world because you want to be able to have data to get regulatory approval in every country under the sun if your drug shows a benefit. And so that was not done. And so the numbers would tell us there's probably 5% of folks who are EGFR and ALK mutated that are in the study. Half of those are getting your immune checkpoint inhibitor. We don't think it works based on, I think, data in the metastatic setting. I don't know that we know for sure it doesn't work in the adjuvant setting compared to placebo. So that's one difference that could explain why the durvalumab study was negative. The other thing that the authors of Br.31 state when they're trying to talk about why their study was negative and others were positive is that they made a PET scan, a whole body PET scan for everybody before enrollment, and that would find folks who actually had metastatic disease, especially because after you do the surgery, it takes some time to heal before you get enrolled. That wasn't the case for Empower 010 or Keynote 091. In fact, 33% or something like 30% of patients who did not go on to be randomized after enrollment in the study That was a couple hundred patients because they ended up having disease progression or a new primary. And so when you look at it, it's hard not to think the Br.31 study is the most representative of what we do here in the United States. And, the hazard ratio for disease-free survival was 0.89, 60 versus 53.9 months median DFS. It was not statistically significant. It looks like there's maybe some benefit, but that hazard ratio, that point estimate, all those numbers are pretty similar to what we see for atezo and pembrolizumab. And my guess is somebody somewhere smarter than me is already working on a meta-analysis, and you're going to find that there probably is some modest benefit to disease-free survival for adjuvant immune checkpoint inhibitor. But it does look to be relatively small here, and I certainly would not be eschewing chemotherapy in these folks trying to rely on adjuvant immune checkpoint inhibitor. So even though it's a negative study, the top-line results are kind of in line with what we see. It just was not statistically significant, especially when, and this study had the lowest percentage of folks who are PD-L1 negative. When you look at those who are PD-L1 positive, it still was not statistically significant in Br.31. So, that's a little bit puzzling why we didn't see benefit here in this study. Maybe it's just chance. I think if there was obvious benefit, if there was obvious large benefit, let me restate that. If there's obvious large impact size benefit, we would see it consistently in all these studies. So I don't think it's going to change the practice. I don't think people are going to stop using atezo or stop using pembro. They're not going to use durvalumab. But I think it does add to some of this data here. We so often think about should we or shouldn't we? I think that the squeeze is for it's a lot of squeeze for a little bit of juice here for adjuvant immune checkpoint inhibitor. And that's despite them being very good drugs for non-small cell lung cancer. That's the thing that's a little bit disappointing is we're not seeing huge separation of our disease-free survival or overall survival curves. Perhaps we see that more in the perioperative setting where you get some immune checkpoint inhibitor before treatment. Okay. If a lot of listeners of this pod tune in because they're new to oncology, trying to get up to speed with treatment of adjuvant non-small cell lung cancer, or they appreciate quick weekly updates to keep pace with the onslaught of new information in oncology, like we're going to talk about with Asco Gu. Well, if this sounds like you, check out the Oncology Insights newsletter, a free weekly email written by fellow OncoPharm Kelly Carlstrom, founder of KLC PharmD and the ELO Collaborative Program. Each week, she shares practical pearls, ways to think through oncology concepts without just memorizing guidelines, and insights on staying motivated and growing in your practice. It's written by a pharmacist for pharmacists, and it's easy to read. You can sign up using the link in the show notes. So to Asco Gu 26. This came across my X space. That's sadly fewer and fewer these days that you get good information from folks. First one I talk about, we got 1.5 practice-changing studies to talk about. The one I'm going to talk about first is LightSpark 022. This is adjuvant pembrolizumab and belzutifan in clear cell renal cell carcinoma that has been resected. We know from Keynote 564 that adjuvant pembrolizumab had a disease-free survival benefit compared to placebo, year of pembro. With longer follow-up out to 48 months, we did see an overall survival benefit as well. So we know there's benefit to adjuvant pembro. So it's adjuvant pembro plus belzutifan, both of those for basically a year, or just adjuvant pembro plus placebo. The inclusion criteria are the same. So these are folks with resected renal cell carcinoma that was either T2, that was grade 4, or sarcomatoid, so had high-risk features, a T3 tumor, or a T4 tumor of any grade, or any node positive. And this did include folks who had metastatic disease that had a metastatectomy, but with no evidence of disease. And that was a huge benefit in the initial DFS study for pembrolizumab in the adjuvant setting. Belzutifan is a drug that I find to be a little disappointing. It's the only drug that has some benefit, and it's progression-free survival benefit in folks who progress on an immune checkpoint inhibitor and an ICI in the adjuvant setting. But it's compared to everolimus, which is not a good drug, a drug that maybe is negative, like maybe is worse. Actually, we have a study. It's worse than just doing another TKI in the advanced renal cell carcinoma space. So when this showed an improvement in disease-free survival, I was a little shocked. I did not think belzutifan would do much of anything. And so you're doing it for a year, and the DFS delta after a year is 7%. 91.9 versus 85.2. The DFS benefit at 24 months estimated 80.7 versus 73.7, delta 7%. At 30 months, delta 7%. We are not seeing those Kaplan-Meier curves separate, even though this is in the curative setting. We would expect, if you cure some people, the disease should not come back at the same rate as the folks who just got pembro. If we really are curing more folks with belzutifan, which is a hypoxia-inducible factor working with VEGF, always kind of puzzling drugs that work on angiogenesis, how they're going to be helpful when there's no tumor. Biologically, it doesn't kind of make sense, and we see that, which is why I made the joke the other day on social media about bevacizumab is like it's the with or without you. It's plus or minus. You never need bev. It's always plus or minus, it seems. Now, it is very early, so overall survival is immature, but we're not seeing any hint of OS benefit. Again, very, very early on. Maybe there's some hint there. So we'll have to wait to see for the publication here. I'm curious to see what folks are getting when they progress, if their disease does come back and recur on the study. I will point out the thing, I was like, I know what's going to happen. When you look at the forest plot, you'll see all the benefit of the belzutifan group is in the M1, no evidence of disease. Folks who are metastatic but had a metastatectomy, you actually are not seeing that. It looks like those folks, that point ratio is 0.96, and it's a small sample size. So, I'm curious for this to be published and to read more about it. I'm a little bit skeptical, even though we have this improvement in disease-free survival. Would like to read more about the study. It is possible, perhaps, that there are folks like we saw in Br.31 who maybe are metastatic or they're not excluded or something like that. There's just something that doesn't sit right with me about that, and I can't put my finger on it, so that's not a reason to adopt this, especially if the publication doesn't have any obvious flaws in our protocol. Now, that's in contrast to the next study, and I point out in LightSpark 22 that we've had, in my opinion, some disappointing results in belzutifan. It's a toxic drug. More people had to stop due to toxicity, so that's also a part of this as well, especially if you put it in a general population. Will they all tolerate the belzutifan? And if you can't tolerate it, do you still see this improvement in disease-free survival? Okay, so let's move on to Keynote B15. This is enfortumab vedotin and pembrolizumab in the perioperative setting for bladder cancer. And you're like, John, you just talked about this. Well, that study that I talked about was in cisplatin-ineligible patients. This is in cisplatin-eligible patients. So I'm coming into this already expecting great things because enfortumab vedotin has OS benefit in the metastatic setting after platinum-based therapy. It has overall survival benefit in the first-line metastatic setting versus platinum-based chemotherapy. Whether you're cis-eligible or ineligible, we have positive data in the perioperative setting for cisplatin-ineligible patients. It sure seems to reason the drugs, this combination would be effective in cisplatin-eligible. Unlike immune checkpoint inhibitors in adjuvant non-small cell lung cancer, we have seen consistent benefit of enfortumab vedotin in bladder cancer, and we see it here in folks who are eligible for cisplatin based on the Galsky criteria, so creatinine clearance, above 60 and no serious heart failure. They can hear, they can do their ADLs, ECOG 0-1, that kind of stuff. So it's perioperative EV pembro. Hold that thought. One more critique of LightSpark 22. I'm going back to this. This LightSpark 22 study is 1,800 patients. It's 1,800 patients. That's almost twice as big as Keynote 564, which showed the DFS benefit of adjuvant pembro. This is a lot more people. There's not 900 people total, like in Keynote 564. I guess 1,000 people total in Keynote 564. There's 920 in each arm. So you have a lot of patients there. And there is a concept of, we worry about studies being underpowered. There is a concept called overpowering, where you have so many people, you are seeing small benefit. Now there's an argument for that for a very, very common disease state, like say atrial fibrillation or heart failure. That's why these cardiology studies have like 1 million people on each arm. So that's something else to think about here. If this LightSpark 22 was 500 versus 500, I do wonder if we're seeing a DFS benefit. Okay. So anyway, keep that in mind. All right, back to Keynote 5 B15. This is a normal-sized oncology study, 400 people in each arm. Again, it's bladder cancer, older. These are guys often. So to find folks that are eligible and older and men and still be a candidate for cisplatin is a select group of folks. So I also want to give the authors credit of this study because the control arm was neoadjuvant Gem-Cis. The French would argue neoadjuvant dose-dense MVAC would be better, that you get more cisplatin. Makes sense. But they did amend their protocol in February of 23 to allow for adjuvant nivolumab. They probably should have done, the study was probably already closed, but we know that neoadjuvant nivolumab with cisgem and adjuvant nivolumab is probably the way to go if you're doing that. But they did allow for that. We see a statistically significant improvement in event-free survival. That hazard ratio is 0.53, very far away from 1. All right, so strong effect size. The delta is 10.6% at 12 months, and that grows to 13.2% at 24 months. So event-free survival rate estimated to be 66%, and the cisgem arm versus 79.4% in the EV Pembro arm. And again, they're getting this basically a year of therapy total of EV and Pembro. Overall survival is also statistically significant improvement, as is pathologic complete response rate, 55% with EV Pembro versus 32%, almost twice as much PCR. The OS estimate at 12 months is a delta of 3.2%. That increases to 5.6% at 24 months, at 86.9% and 81.3% respectively. We do see that delta separate and get larger as we go on, suggesting we are curing more folks up front with EV Pembro. So while the Pembro belzutifan, I'm like, let's wait until we see the publication. If you've got someone that you're getting cisgem orders in the neoadjuvant setting, it's probably worth saying, hey, have you heard about Keynote B15? We know safety data of EV and Pembro together. We have this at ASCO GU. This is going to be adopted in the guidelines as the way to go. Sell your shares, sell your actual drug, cisplatin, because you're going to be using it less in our bladder cancer population. Still would be a candidate for these folks, cisplatin, after they progress, if they're a candidate at that time. So that is what I have for you this week. Some updates. It's all immune checkpoint inhibitors these days. Each of these 3 studies were immune checkpoint inhibitors. Thank you so much for listening. You can follow me on Twitter at PharmDeetnib and the podcast on social media platforms at UnclePharmPod. And until I talk to you again, remember, doses matter.